Thank you all for coming. It's so nice to see so many familiar faces from a long time now. Thank you to the organizing committee for asking me to speak today. We're going to talk about a topic that's not talked about that much, and that's kidney disease and pregnancy. Just to gauge the audience, how many of you take care of dialysis patients? Okay. How many take care of CKD non-dialysis patients? And transplant patients? Just the three gentlemen over here. And home-based therapies, home hemo. And how many people have nursed someone or cared for someone through a pregnancy in dialysis or CKD? Yeah, so not many. So we have a whole side of the room. So this will be new to some. And what I really want to get out of this hour is just to give you an appreciation of what our patients face when contemplating a pregnancy, talk about thinking about pregnancy in your patients of reproductive childbearing years, and then talk a bit about what the outcomes are and how we can plan. And I think I've left quite a bit of time for questions. I have no disclosures related to this talk. And we've learned a lot in the last 30 years. It used to be the advice from physicians that if you were a kidney patient and if you got pregnant, number one, you shouldn't get pregnant. And number two, if you did get pregnant, in most cases, you should terminate that pregnancy because of the high risk. And a lot of times this was an anecdotal risk. It just didn't seem like a good thing to do. So we've actually learned a lot, and a lot of the data I'm going to show you comes from not that many women. And we'll talk about what is known since women have had babies in CKD and on dialysis. So again, the goal today is to have you leave here today thinking about your patients who may be in their reproductive years and having conversations with them about their wishes, what they think is going to happen, what they've been told so far, and know who to ask because we won't have all the answers by the end, but just to have that discussion. So before we start talking about what is how a kidney with CKD adapts, we'll just do a brief discussion about how your kidneys that are normal, adapt when going through a pregnancy. We'll talk a bit about those in CKD not on dialysis and how they end up doing after they go through a pregnancy. We'll talk about people on dialysis when they conceive, and we'll talk a bit about the transplant patient, and then we'll talk a bit about counseling. So this is renal physiology in pregnancy 101. It's not going to be a lot of kidney physiology. It's just going to be the basics of what happens to normal kidneys when you're pregnant. So the kidneys get bigger. It's pretty amazing. The kidneys get about 30% bigger in pregnancy, and they'll be about 1.5 centimeters longer when you do it on ultrasound. And the ureters and the renal pelvis dilate, and they dilate to hold about 200 to 300 mils of urine just in the ureters and the renal pelvis, which makes you kind of understand why women who are pregnant always have to go to the bathroom. They might get UTIs. It's quite a non-physiologic, it's physiologic, but it's quite different than the norm. And the bladder itself has a lot of blood supply and is a bit edematous. And this is a picture of this is a CAT scan. So for those of you that don't read CAT scans, you can kind of pretend you're looking at the patient from their feet. So the right is the left. And this is a normal kidney in pregnancy. And this is the right kidney, and this is the left kidney. So you also get some physiologic hydronephrosis, or a bigger kidney, due to a bunch of factors, one being the compressive effects. That can stay there for 6, 12 months, even postpartum sometimes, and it doesn't reflect any blockage. It just reflects I guess it is a blockage, but it's not of any consequence to the GFR, the kidney function. You get about 50% more GFR in pregnancy that peaks even by the second trimester. And so the kidneys have to work a lot harder. And your urine protein does go up, but doesn't usually go up more than, say, normal protein in 24 hours is 150 milligrams a day. It might go to 300 milligrams a day. And for those of you familiar with what that means with protein to creatinine ratios, that's about 30 milligrams per millimole. So anything higher than that in pregnancy in a normal person is considered an abnormal value. And us in the kidney world use albumin to creatinine ratios a lot more. And although the obstetric world hasn't used them routinely, that would be about an ACR of about 8, where 2 is the normal for an ACR. So that's normal pregnancy. Your creatinine will go down in pregnancy. You can sometimes know your patient's pregnant before they do by seeing their creatinine that's 20 points less than it was before. It does this in the first trimester and usually peaks in the second trimester. And you want that to happen, and these are in the normal state. So the average creatinine in a non-pregnant woman is 72. The average in the third trimester is only 46. So that's physiologically normal. So if you get a patient, say you have a patient with polycystic kidney disease and they have a preserved GFR, you're going to want that creatinine to see that creatinine fall. And if it doesn't, that might make some marker that maybe the kidneys aren't compensating as they should. So if you have a pregnant woman with preserved function in your clinic and their creatinine's 80 in pregnancy, never normal, because it should have been falling. So I'm going to introduce you to one of our patients that we've followed through that's delivered about a year ago now. 28-year-old Filipino woman. She was a nurse, and then she is working as a caregiver. And at age 20, she was diagnosed with IgA. She's now about 10 weeks gestation, and her creatinine is 228. Her blood pressure is normal, 130 on 80, but maybe not normal for a young woman, and her urine ACR is 120. Pre-pregnancy, her creatinine was 196, so it hasn't gone down, it's gone up. Her blood pressure, 130 on 80, and her urine ACR was 60. She was on an ACE inhibitor, but as soon as she found out she was pregnant, about 6 weeks, she stopped it. So you're meeting her Friday afternoon, and she's asking you, what should I do? And what's going to happen to me? So whenever you have a woman who's thinking of being pregnant or pregnant, you say, and especially in CKD or on dialysis, you say, what's the effect of the pregnancy on this kidney disease? And then conversely, what's the effect of kidney disease on this pregnancy, both for mom and for the fetus? And so just like in CKD, there's a few factors that are going to be really important to help prognosticate how things are going to go. GFR, blood pressure, and proteinuria at the start of the pregnancy. And so I made it up, it's very corny, but good baby planning. So whenever I see a patient, I say, okay, good baby planning, what's the GFR, what's the blood pressure, what's the proteinuria at baseline, and that kind of sets my stage. Many of you have seen this, but just to refresh those that haven't, the reason those things are so important is what we're learning in nephrology is that it's not just your GFR that portends bad outcome. It's your GFR number and your protein number, your urine protein. So that someone that has a GFR of 30 but no protein has about the same risk of bad things happening, progression of their kidney disease, as someone with a preserved GFR, but their protein is already high. So you have to take the protein and the GFR together, and in pregnancy, also with the blood pressure. And you'll remember that our patient was starting out in one of those dark red boxes. So she had a GFR in the 20s, and she had a lot of urine protein already, an ACR of about 60. So my first big message is that women with kidney disease can get pregnant, but my caveat message is any kidney disease, any pregnancy in kidney disease is high risk. The diseased kidneys sometimes can't adapt to the normal physiologic changes of pregnancy, which we just talked about, which can lead to complications. And we're going to talk about some of the complications that are possible. So for mom, the big complications are that their kidney function will go down, that their blood pressure will go up, that they'll get more protein, that they'll get pre-eclampsia. On the fetal side, preterm delivery is almost the norm, and I'll show you how preterm, because whenever I say preterm to a mom, she says, what does that mean, how preterm? Small for gestational age, and growth restriction. So this is actually the biggest study we had until recently in CKD patients. So this was 67 patients, 67 in the New England Journal of Medicine, and it looked at people, this is people with creatinines of less than 125, 125 to 180, and higher than 180. And it said, how likely were you to lose 25% of your kidney function during a pregnancy? And if your creatinine was 125 or less, it was pretty unlikely. But as the creatinine got higher, your chances of losing up to 25% of your kidney function in the pregnancy went up. How likely are you that it'll stay low? So persistence of that loss. And if your creatinine is less than 125, less. And as you got higher, as you got a lower GFR, your chances got higher. And how likely would you be after a year of your pregnancy to be on dialysis? And in those that started with a creatinine of 180, almost 50%. So that's a little hard to read, so used another way. And again, we're using these just because those are the numbers the study showed, right? Anyone with some common sense would say, well, there's nothing magic about being 179 versus 182. It's just that the magnitude of risk as your creatinine gets higher, your outcomes are worse. So in this study, it showed that if your creatinine was less than 125, most people during that pregnancy did okay. If your creatinine was higher, about 50% chance that your kidney function would start to go lower. And if your creatinine's higher than 180, at least over half, so at least 70%, it'll probably stay lower, and 23% progress to end-stage kidney disease within 6 months. And we'll get back to some of those numbers. So take-home point number one is whatever your GFR is when you start really does portend how well you're going to do, and the lower your GFR, obviously, the more chance of complications. Let's add on someone that has high blood pressure. So someone that has high blood pressure going into a pregnancy, even without kidney disease, has about a 30% risk of preeclampsia. Someone with kidney disease has about a 50% risk, all comers. So if you put both together and they have that, of your good baby planning, they had the CKD and the hypertension going in, about an 80% risk of preeclampsia. Preterm delivery is quite a frequent occurrence. Lower birth weight, need for NICU or neonatal intensive care, and perinatal death. So definitely having the high blood pressure with the CKD is an additional risk factor. So how about the protein? So proteinuria is something we knew was bad a long time ago, but just recently we've started quantifying people's protein, right, their ACR numbers. Having proteinuria present in early pregnancy will increase your risk of your kidney function worsening over time. Now, even without a pregnancy, having proteinuria does that, but the pregnancy does add an additional insult. And it is another risk factor for losing GFR in pregnancy. We don't really know about the obstetric outcomes. So we have women that have very preserved GFRs, but have a lot of urine protein. And it does look like you do have a bit of an increased risk of preeclampsia, which would make sense, but those outcomes aren't as correlated. And of course, if you have someone unfortunate enough to have nephrotic syndrome in pregnancy, nephrotic syndrome is when you lose lots and lots and lots of protein, you get really swollen. Well, pregnancy, you also have increased blood volume, get swollen. Your risk of edema, your risk of blood clotting, everything does go up, and you're shunting that away from the uterus and the placenta. And this one's hard to read, so I'll give you the so what point. So I'm often asked, okay, my GFR might go down. I'll reach a new number, but is that slope, so that change, when you look at your patients, say you're changing it 2 mils per minute per year, is that slope going to get worse? Am I going to do this, reach a new baseline and continue to do this, or I'm going to go like this, reach a new baseline and go like that? And we're not sure. Oops. But what it looks like is that if you have a low GFR to start with, less than 40, and proteinuria, those are the people that actually did have a worse slope, so a faster decline after their pregnancy. The fetal outcomes as well are actually not as good in people with both protein loss and a low GFR. And this one's hard to see, so I'll just read out the pertinence. The birth weight, if you can see the birth weight column, the birth weight of people with GFR above 40, 2.5 kilos. The birth weight of someone less than 40 but good, no protein, 2.2. GFR less than 40 and protein, 1.8. So 1,800 grams. So it does seem to have lower birth weight babies. The percent of the pregnancy duration, about 35 weeks, but those with both protein and a GFR less than 40 in this study, about 33 weeks. So that's in terms of the numbers that we're talking about. So good baby planning, the GFR is important. We think the blood pressure added on is important as well, and the amount of protein they have is also a predictor. Now, up until recently, it was just 125 creatinine and less, they do okay. Well, we must get a little bit better than that because, as you guys know, a young woman who already has a creatinine of 125 has lost almost half her kidneys. So how about those women with polycystic kidney disease that still have a preserved GFR and just some proteinuria? Are they okay? How about people that have IgA nephropathy but their creatinine is still 90? How about them? So this is a large Italian group who looked at people with earlier stage CKD. And again, they looked at people with CKD stage 1 and 2, and I'll just draw your attention to their GFRs. So their GFRs in stage 1 were 139, and their GFR in stage 2 was 77. And I'll show you the outcomes. So no matter what the stage, the people with, even with CKD stage 1, so preserved GFR, but just something else, protein or some diagnosis, actually did worse. And the kind of dose effect is quite amazing. So you can see for preterm delivery, CKD stage 1, 28%, stage 2, 42%, 82, 100%. There are only 4 patients, but 100%. So a lovely, as CKD get worse, preterm delivery became more. The gestation, look at this, 37, 36, 34, 32. So it's a lovely guide to say, okay, where does my patient fit in and where do I anticipate them delivering, which really helps the patient know, because if the patient thinks they're going to have a 40-week pregnancy, they're going to be set up to think that something went wrong. If the patient thinks they're going to have a 36-week pregnancy and are planning around that, it actually really changes the dynamic of that pregnancy if they know. Their birth weight, so average birth weight of all comers in Italy is 3.2 kilos. 2,800, 2,500, 2,100, 1,246. So that's, under a 3-pound baby. And so a big difference in birth weight and a big difference of when you deliver. So this can help us inform patients. So summarizing the risks is hard, and I would never tell patients you have a 23% risk of IUGR, but a 21% risk of preeclampsia. The way, in general, patients seem to relate this is if your creatinine is relatively well preserved, about a 30% chance of one of these IUGR, preterm delivery, preeclampsia, about a 30% chance. Perinatal mortality, low. Loss of kidney function, pretty low with this pregnancy, but not normal risk, right? If your creatinines are in this range, about a 50% chance of these things happening, 1 in 2, people can understand that. And about a 1 in 2 chance you will lose some kidney function with this pregnancy. And if your creatinine's in the higher range, then almost, over 50% chance. It's more likely than not that you're going to develop these complications. And it's more likely than not that you're going to lose some kidney function with this pregnancy. And so let's go back to our patient. So remember, pre-pregnancy, her creatinine was 196, so in that highest range. Blood pressure was okay, and her urine ACR was 60. We counseled her with respect to the risks, and she decided to proceed with the pregnancy. The risks I gave her, I said the birth will be preterm, and there is over a 50% chance of IUGR and preeclampsia. There is over a 50% chance you will lose kidney function, and it may be a permanent loss. And about a 30% chance you'd be dialysis dependent within 6 months. And all of these have to be contextualized in what would happen to the patient if they didn't get pregnant. Because it's not that if she didn't get pregnant, she'd have normal kidney function for the rest of her life, right? And often sometimes when they come to see me, that's the first thing I say is, what do you know about your kidney disease and your renal health? And that's sometimes a very sobering discussion because there isn't that understanding of where they are in their renal trajectory. So you have to start with that because this looks awful, right, if it's just taken into context. Sometimes awful, sometimes not, because patients will have a strong desire to do what they want to do and will read this any way they want. So she, of course, decided to proceed with the pregnancy. And then the question comes, is there anything I can do to reduce these risks? Anything the patient can do, anything we can do as her providers? So there are a few interventions that help lower these risks. One is taking a baby aspirin. The baby aspirin helps lower that chance of preeclampsia. We do it in all high-risk women, so basically anyone I would see, I would say almost. You start in the first trimester, and you can continue up to delivery. And the biggest question I get from this one is, after talking all about those risks, they say, I don't want to take anything, it'll hurt the baby. And it's like, okay, well, this might help the baby. So it's quite interesting how people perceive risk. Calcium supplementation, especially in our patients, because often their diet has a lot of calcium restriction, right, because of the phosphorus. So a very good dietary inventory and supplement with calcium, if it's not there, has been shown to be beneficial. And there have been a lot of different vitamins and minerals and supplements along the years. These are the only 2 right now that are considered to help. The other thing is blood pressure. So if you look up quickly, or the patient looks up, what should my blood pressure be in pregnancy? It's a different set of rules if you develop high blood pressure in pregnancy versus if you're a CKD patient with high blood pressure already. So the take-home point is you actually want your blood pressure to be at your target range if you can throughout your pregnancy. So 140/90, 130/80, somewhere in there. We have a different target than the targets for blood pressure if you develop it in pregnancy, which the literature shows you can actually let go up a little bit. And then often in our practice, we have people that already come on an ACE or an ARB and they didn't know they were pregnant, and they're freaking out because when you Google ACE and ARBs in pregnancies, you get some really not nice pictures. So in the first trimester, it's actually pretty much okay. So if you stop it before about 10 weeks, they're on average not really that much of a problem. So you can reassure the patient that it's all right. Second and third trimester use you cannot use. The amniotic fluid goes low, baby stops peeing, can cause actually renal failure and death. So it's an actual really alarming thing in the second and third trimester. Hopefully women don't get to that point still knowing. We have had even dialysis patients not knowing they were pregnant. Just make sure the patient stops it as soon as they know they're pregnant. So what happened to her? So she carried on with the pregnancy. She was seen basically almost every week. Her blood pressure did start go up. What happens with normal blood pressure is it should fall in the second trimester and then start rising near the end. Her blood pressure actually started going up in the second trimester, and she was started on therapy. The protein continued to increase, and if you start out with protein, it is going to continue to increase. And at 28 weeks, everything else was stable, but her creatinine started going up and started getting swollen. And it's a really hard decision to say, is this something we have to deliver the baby, or is this the kidney disease getting worse? So we thought it was actually more the progression of kidney disease. So she was started on dialysis. She was started on extended dialysis, and I'll go into that in the next part. And then she was induced at 35 weeks. And this was Evan. He was 1,850 grams, premature but well. She could come off dialysis. Her creatinine went to about 225, so 197 and then 225. ACR kind of went back to where it was, and she got back on her ACE inhibitor, and her husband is currently being worked up as a donor, and some other donors as well. So she had the high blood pressure, she had the protein getting worse, she had IUGR, she had preterm delivery, she had almost every complication we put on. Was this a successful pregnancy? She says, absolutely, right? Absolutely, this was successful. So the risks have to be contextualized with the patient's experience. So that's the CKD world, and that's the majority of patients that you'll see, other than transplant. How about people on dialysis at conception? So women are often discouraged from getting pregnant when they're on dialysis, and oftentimes they can't get pregnant because they stop having periods. There's a lot of reasons why they don't. But if you ask them what they've been told in the past about pregnancy, sometimes it's quite interesting. And if you look at the DaVita website, one of the big US right now, so this was from last night, it says, is pregnancy recommended for women on dialysis? Pregnancy is generally not recommended for dialysis patients because it's high-risk pregnancy. It says having extra waste in the body makes it harder for the baby to develop as it should. And that's what if you say, should I get pregnant on dialysis, that's what's out there. And it's true that until recently, the chances for pregnancy when you were on dialysis was considered to be nearly non-existent. Reported chances of a successful pregnancy in women of childbearing age on dialysis was 0.9% in the 80s to 2% in the 90s. And in 2015, though, 15% with frequent dialysis. Previous quotes were about less than 50% survival of the baby. And this is from the Ontario, from London, and they have an extended duration dialysis program there. And this is this woman here on dialysis that had a baby, and she said, I knew that the transplant would change my life, and I wanted that kidney, but I wanted a baby a lot more. And from that point, I knew that my life was going to be so much more amazing because of him. So often on dialysis, people are told, wait till you have a transplant. Transplant will restore fertility, and then you'll go on and have a baby. Sometimes, though, you have to say, okay, when would that happen, right, as the provider? They're 34 now. They've never been pregnant. They're on the deceased donor list. They're a B or an O. So we're basically giving a bit of false hope. What else can we do? So she was kind of in that situation. And even women that have a potential live donor, we actually suggest they wait. We tell them they wait a year after their transplant of a stable graft function before they attempt pregnancy. And sometimes we don't tell them that before. We say, after your transplant, you can have your baby. And sometimes they're 35 when they have their transplant, then 36, then trying to conceive. So we do know that the chance of conceiving is reduced. There is a lot of infertility. There's a lot of depression, there's sexual dysfunction, there's anxiety, there's a lot of comorbidities that make it hard to conceive. The risks to mom and the risks to the fetus are basically everything I talked about in the first section, just plus, plus, plus. So there is a risk of the hypertension getting more severe, pre-eclampsia. I would say all babies are premature. Most are quite premature, but I'll show you some encouraging data. Can anything be done to make that fertility better for those patients on dialysis? Is there anything we can do to improve pregnancy outcomes? So there's a couple places that have made a focus of this, and one is Australia, and we have a colleague here who practices there, which I would have put that data on as well. There is a Toronto cohort that has 22 pregnancies and 17 patients, so these are small numbers. And they gave them an average of 43 hours a week chemo, compared to the US, which really didn't do this, and they had an average of 17 hours per week. And the difference in live birth rate was 52 or 85.7 in those with more frequent dialysis. And the mean gestation, so 40 weeks normal pregnancy, 36 weeks, pretty good, versus 27. And there's a strong dose relationship between how much dialysis you get and how the baby does. So this is getting 0 to 20 weeks on dialysis, live birth rate 48%, 21 to 36 hours of dialysis, 37 to 56 hours of dialysis. So the more hours of dialysis, the more likely. Now with that, the woman I showed you, she actually went on nocturnal in order to allow herself to have menstrual periods and then conceive. So there is equal evidence that says the more dialysis you do, the more likely you are to actually be able to conceive. Of course, since they're rare, usually we quickly look up what to do with these patients when we have a pregnant patient on dialysis. But the main things are they have to get lots of it. Their blood pressure has to be quite well controlled. Imagine how you estimate volume removal and dry weight in a pregnant woman who every week is gaining. They need a lot more EPO. They need a dietitian that is just kind of figuring out their protein needs, their supplement needs. They need fetal monitoring during hemo once they reach viability. And, you know, this is only case reports, but for those that do PD, if someone conceives on PD, the general recommendation, if they already conceive on PD, is to keep them on PD. I have not myself looked after a woman on PD who's went through a pregnancy. I don't know if anyone else has. There we go. I think he's here. Yeah. So how about probably one of the biggest populations? So people that have had a kidney transplant. So young women that have had a kidney transplant. Does having a baby hurt their kidneys? What are the outcomes for these women? So kidney transplant for sure improves reproductive function, and it does so quite quickly. So women who are on the transplant wait list and then successfully transplanted and are of childbearing age should be told that this may happen because they might not have been using contraception before, and they should be using that post once they've regained their cycles. And this is a stat worldwide, which is quite amazing. Over half of the women living after a kidney transplant now are of childbearing age. So there's a lot out there. And I think we could even do a better job at preconception counseling of these women, family planning. I think it's a really important component of care. We could standardize better than we're doing. And so what are the risks and outcomes of pregnancy in the kidney transplant recipient? And I know I show this slide a lot, but this is pretty amazing. So this lady is Edith Helm, and she's a lady of many firsts. So she was the first lady to get a kidney transplant in 1957. She was the first lady to have a baby after a kidney transplant, and she had 2. She was the first lady to defy doctors' advice to not have a child because it would hurt the baby. Her sister had 3 babies, and for those of you who know about kidney donors, there is this risk coming up of maybe there's some problems with pregnancy outcomes. So 5 kids between them. And then her graph, she was the longest living woman on dialysis. So she died after 56 years with a kidney with a creatinine of 60. So it definitely can happen, and sometimes we need these brave ladies to pave the way. And so I can usually reassure women that if their kidney function with a transplant is normal prior to going into the pregnancy, it would stay normal. So the overwhelming evidence is it doesn't hurt the kidney to have a pregnancy after a kidney transplant. But the other risks are the same as the CKD population, because if their GFR is low, they have proteinuria, they have hypertension, then they have an elevated risk. So the good news is, I usually start off with the good news when people ask. I say, the live birth rate and the miscarriage rate for a kidney transplant patient is actually lower than the general population. So that's why those 2 are in black. It's actually lower. So you have a better chance of a live birth and not having a miscarriage. And that's probably a bit because we take care of these people like crazy, right? And they're very well screened, and the ones that get pregnant are the wellest. But it's the good news. The risk of pre-eclampsia is there, gestational diabetes, preterm delivery, and a lower birth weight. And when you look at all the numbers, usually about a 35, 36-week pregnancy is kind of the norm, and usually about 22, 23, 2,500 gram baby. Now, people defy this all the time, but when you set those expectations of what low birth weight, because as soon as you tell someone they're going to have a premature baby, they have the worst things come to mind of prematurity. Women that are younger, women that have normal blood pressure, women that have normal kidney function, and the longer since your transplant, the better the outcome, but not that much different. So if you have a woman who's 9 months after her transplant and there's something, and everything is stable and she wants to conceive, there's no magic number at the year mark. We do have to do a bit of homework. So MMF, or mycophenolate, that almost everyone is on, is teratogenic. So there are risks of birth defects with that, so it has to be switched prior to conception if possible. Sirolimus is contraindicated as well. The other ones, if you look them up, will say a lot of things. In general, we have 10,000 patients that have had transplants and had babies, and in general, they are considered safe. The doses of things like cyclosporin and tacrolimus need to be upped amazingly because women's volume of their body volume gets bigger, and these drugs sometimes need double the dose they were on. So you wouldn't want to underdose a woman when they're pregnant. But in general, they're considered safe. But you should probably take a look at what the websites actually say, so you can say they're considered safe. This is the evidence. I do know about the evidence that you're going to see. In our experience, they're safe. And so when can I have a baby? And I think a lot of times people delay because things aren't optimized. And as soon as the patient is as medically optimized as they're going to get, that would be the time, because what they have to realize as well is that renal function and fertility will decline over time. So kind of no time like the present if things are stable. Blood pressure, blood sugars have to be controlled. In general, the rule is to wait a year post-transplant. And if you have someone in your CKD clinics that is over 35 and they're progressing, you might not say, wait till your transplant, because wait till your transplant might mean they're 39 by the time that all gets done. It might be, I how serious is this in your life plan? We might want to start you on dialysis earlier, get you on nocturnal, get your cycles going, see if we can help you. The renal clinic that we do with obstetrics is open to anybody, so anyone that wants to ask questions or advice or have a patient. We do a lot of telemedicine just as a preconception counseling visit, so if you want to spread the word, we're happy to do that. We have an obstetrician, we have maternal fetal medicine, we have specialists in internal medicine and obstetrics that can help consult. And we follow patients at least every 2 weeks to weekly once they reach viability. And we do ultrasounds at least monthly of the baby and kind of make that jump when to actually deliver the baby. So I hope today, I think this is the last slide, is to impart that patients with kidney disease can have successful pregnancies, but they're always high-risk pregnancies. No kidney disease is trivial in pregnancy. Think about it. If you go back to your practice and have a patient in childbearing years, think about it. And if they want some preconception counseling, talk to your nephrologists. And all of these patients should be followed in a multidisciplinary high-risk pregnancy team throughout the pregnancy. I think that's it. Any questions or anecdotes? Or Marie? Exactly. Yeah. Because both to avoid the mixed messaging and then just to make it easier for the patient. Yeah. They see you one at a time. Yeah. We've lost the rooms, so the cheat is that we actually now have our private offices located beside each other so that we book our appointments so that they see one and then they see the other, and then we text each other the the review. But in the hospital-based, we are all there at the same time. Yeah, yeah, yeah. Usually with the interior, they come for a preliminary visit, the people I've had, and then they're just co-managed after. And it's up to the patient if they want to come down for that initial visit because their obstetric team will be in their home authority. Sometimes women in the Fraser have actually asked to deliver, at the same place, so we deliver at St. Paul's. The obstetric, lower mainland obstetric teams have been very, because people cross those borders so much, we have care plans actually at every hospital. So as soon as we have a woman in our clinic, we actually will fax an updated care plan to women, St. Paul, Surrey, everywhere, just so they all have it and know of the woman. But usually for that counseling, that's all we can do because we can't adequately manage a woman that lives somewhere. It's not fair to them, right? So we usually just do a first visit. And we're happy to do it over the phone as well and follow through. We do that on the island quite a bit. Yeah. Yeah. It's mainly getting enough volume to adequately do peritoneal dialysis. It is not the effect of the volume on the baby, but there's a lot of baby in there, so space might become an issue. Yeah. Yeah. So how can you do fluid removal goals for someone that's pregnant? You can kind of guess to start that a woman should gain about 500 grams in, a week's period, and so you can do that. Often it's doing it very similar to what you're doing and just adding what a normal growth would be. If you have an ultrasound and have baby growth, that's helpful, but a lot of weight is not baby, right? It's everything else. So it's hard. It's hard. Yeah, the average is half a kilo a week. So they have more frequent ultrasounds just to determine the growth? Yeah, they have weekly ultrasounds. Hmm. I don't, but I will have it very soon. We just have a link. Actually, you're sitting next to the statistician that is doing the linkage with the perinatal registry to get exactly that data. Yeah. So. Yeah. Yes. Yeah. So that I have not cared for one myself. Victor, have you had a bead? Okay. Yeah. Oh, right. Yeah. 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 Yeah, I think we would learn and take each case case by case, and I think what we've learned now since then is the volume of clearance, the amount of dialysis required, and if you're not meeting that on one therapy, like Dr. Tamal, you'd switch to another therapy, and depending what the patient would decide to do. I think that patient was one of the reasons we started the clinic, because her obstetrician, I have an 11-year-old who I was in with the obstetrician. She goes, "Do you know anything about PD and pregnancy?" I'll find out. Yeah. Any other questions? Yes. Yeah. We're just starting to get data on the kids afterwards, school age, performance, and in general, they're quite healthy kids. Yeah, in general. Yeah, they say now 7% for of actual pregnancies in women that want to get pregnant, but I don't think there are many places that do concerted efforts to increase dialysis, ensure ovulation, but about 7% will fall pregnant. Yeah. Hmm. If the baby was born and didn't die. No. Well, unless they had a genetic condition that was inherited, it would not increase the risk of kidney disease and failure. Yeah. So a mom with polycystic kidney disease, the baby would have a 1 in 2 chance, but otherwise, not unless it's an inherited condition. Yeah. Yeah. Yes. 6 to get at least 40 hours a week. Yeah. Yeah. Yeah, so a lot. So that's the other thing you tell women, right? Because sometimes your CKD women know what dialysis is, and when I quote them, you have a 30% chance of needing dialysis. I say it's not just any old dialysis, right? You'll basically live with us for this long. So they really understand what that means when they start out. Yeah. 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 Again, we're just talking about numbers, but maybe after this talk, a lot more. Yeah. That's right. Yeah, Shelley. Yeah. Yeah. It's just another risk factor we have. We've had some that have done remarkably well. We have a young lady that we're just following through her second pregnancy. There's it does depend on type 1 versus type 2 diabetes, and all the risk factors. So their eyes can be an issue because, you know, everything can be an issue. So it just adds another layer, both about their long-term health and then the stuff you have to do while they're pregnant. Yeah. 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 So the question is, if you're a failed transplant who wants to get pregnant, does your failed transplant kidney have to come out? So, no. Yeah. Good. All right, thanks for the questions.